Welcome, everyone. Let's begin by establishing a clear clinical definition of multiple sclerosis. MS is fundamentally a chronic, immune-mediated inflammatory disease restricted to the central nervous system. When we examine the underlying pathology, we see a triad of focal demyelination, the stripping of the protective myelin sheath, axonal loss, where the nerve fiber itself is damaged, and gliosis, which is the reactive scarring or sclerosis from which the disease takes its name. However, the most critical aspect of this definition for your clinical practice is the requirement that neurological deficits be separated in space and time. This means we must identify evidence of lesions occurring in at least 2 different anatomical locations within the CNS, and these events must occur at distinct chronological points. This hallmark concept of dissemination is the cornerstone of the MS definition, distinguishing it from a single localized neurological event. Moving to the etiology and pathophysiology, it is important to understand that while the exact cause of multiple sclerosis remains unknown, it arises from a complex interplay between genetics and environment. On the genetic front, the HLA-DRB1*1501 allele is a primary susceptibility factor. However, this genetic foundation typically requires environmental triggers, such as vitamin D deficiency, smoking, or prior Epstein-Barr virus infection, to initiate the disease process. Pathologically, MS is defined as a type 4 cell-mediated hypersensitivity reaction. In this process, autoreactive T cells successfully breach the blood-brain barrier. Once inside the central nervous system, they orchestrate a targeted attack on the myelin sheath and the oligodendrocytes. This results in the formation of inflammatory plaques and significant demyelination. Over time, this chronic inflammation leads to permanent axonal degeneration and the characteristic scarring, or sclerosis, that gives the disease its name.
Moving to the clinical diagnosis, identifying multiple sclerosis requires recognizing its characteristic presentations. We often see optic neuritis, a painful unilateral vision loss involving a central scotoma and impaired color perception. Ocular motility issues are also common, specifically internuclear ophthalmoplegia, or INO, characterized by impaired adduction of the ipsilateral eye, with nystagmus in the abducting contralateral eye. Listen for reports of Lhermitte's sign, an electric shock sensation radiating down the spine during neck flexion, and Uhthoff's phenomenon, where heat exposure temporarily worsens neurological symptoms. On examination, look for cerebellar signs like ataxia and Charcot's triad, scanning speech, intention tremor, and nystagmus. Motor and sensory deficits typically involve upper motor neuron signs, such as spasticity and hyperreflexia, alongside various paresthesias. Finally, evaluate for autonomic dysfunction, including urinary urgency, constipation, and erectile dysfunction. These diverse findings together form the essential clinical picture of the disease.
Moving to the 2017 McDonald Criteria, our current gold standard for diagnosing multiple sclerosis. The cornerstone of this framework is establishing 2 specific parameters: dissemination in space and dissemination in time. To satisfy dissemination in space, or DIS, we must identify at least one T2 hyperintense lesion in 2 or more characteristic CNS regions: the periventricular, cortical or juxtacortical, infratentorial, or the spinal cord. We are essentially confirming that the pathology is not isolated to a single anatomical location. To satisfy dissemination in time, or DIT, we look for evidence of separate inflammatory events over time. This is demonstrated by the simultaneous presence of both gadolinium-enhancing and non-enhancing lesions on a single MRI, the appearance of a new lesion on a follow-up scan, or the presence of CSF-restricted oligoclonal bands. These criteria provide a rigorous, standardized approach to identifying MS early and accurately. Moving on to investigations. Our first-line tool is an MRI of the brain and spine with gadolinium enhancement. We are specifically looking for high-signal T2 lesions and the classic perpendicular Dawson's fingers. However, the gold standard for diagnosis remains the McDonald Criteria. This requires us to prove dissemination in space and time using both clinical and radiological evidence. To support the diagnosis, we utilize 3 key tests: First, a lumbar puncture to identify CSF-restricted oligoclonal bands, found in 90% of patients, and an increased IgG index. Second, we use visual evoked potentials. A delayed P100 latency here is a hallmark of optic nerve demyelination. Finally, we must perform blood tests to exclude mimics. We specifically screen for vitamin B12 deficiency, syphilis, and neuromyelitis optica antibodies. This comprehensive approach ensures we meet the rigorous diagnostic requirements for multiple sclerosis while ruling out look-alike pathologies.
Moving to management, our strategy is threefold: treating acute relapses, utilizing disease-modifying therapies, or DMTs, and addressing symptoms. For acute relapses, we use high-dose methylprednisolone, 500 milligrams to 1 gram, administered IV or orally for 3 to 5 days to accelerate recovery. Crucially, always exclude infection, such as a UTI, before starting steroids, as infections can trigger a pseudo-relapse. Regarding DMTs for relapsing remitting disease, first-line options include Beta-interferon, Glatiramer acetate, or teriflunomide. For active or rapidly evolving disease, we escalate to high-efficacy therapies like Natalizumab, Fingolimod, Ocrelizumab, or Alemtuzumab. Importantly, JC virus status must be confirmed before starting Natalizumab to mitigate the risk of progressive multifocal leukoencephalopathy. Finally, symptomatic management is vital. We address spasticity with baclofen or gabapentin, fatigue with amantadine or lifestyle modifications, neuropathic pain using amitriptyline or pregabalin, and bladder dysfunction with oxybutynin for urge symptoms or intermittent catheterization for retention.
Let's focus on these high-yield MRCP pearls for multiple sclerosis. In the lab, look for oligoclonal bands present in the CSF but not the serum. Clinically, an internuclear ophthalmoplegia, or INO, in a young patient is MS until proven otherwise, signifying a lesion in the medial longitudinal fasciculus, or MLF. On imaging, Dawson's fingers are your diagnostic hallmark. These periventricular T2 hyperintense lesions sit perpendicular to the lateral ventricles. Remember that optic neuritis is the most frequent presenting symptom, so always check for a relative afferent pupillary defect, or RABD. Regarding therapeutics, Natalizumab, the anti-VLA4 antibody, is highly effective but requires vigilance for PML caused by JC virus reactivation. Finally, consider the role of vitamin D. Supplementation is increasingly recommended as low levels are directly linked to higher relapse rates. Master these specific associations and you'll be well prepared for any MS clinical scenario.
And that brings us to the end of today's session. I hope this has been a valuable and clear overview. To truly consolidate this knowledge, I encourage you to take the next step. Visit our online platform at MRCPELITE.com. There, you can create a free account instantly. You will find a structured slideshow summarizing today's topic, followed by 2 dedicated self-assessment tests, one for MRCP Part 1 and another for MRCP Part 2, each containing 20 focused questions. Take these tests to actively engage with the material. The platform will provide you with an immediate score and, most importantly, detailed, illustrated explanations for every answer, helping you fix the information firmly in your mind. To supercharge your preparation, consider upgrading to a pro user subscription. This unlocks powerful tools, unlimited disease-specific search queries, unlimited access to high-yield exam pearls, unlimited interactive flashcards, and most critically for your exam readiness, full exam board access with 50 question banks for every MRCP subject, and realistic mock exam simulations for both Paper 1 and Paper 2 that closely mirror the actual exam environment. For a limited time, we are running an exclusive offer. Gain all these pro benefits for just $50 for a full year, a significant saving from the standard price of $250. So, head to MRCPELITE.com now. Start with your free account, test yourself, and explore how the Pro upgrade can transform your revision journey. Thank you for your time and all the very best for your studies.